Hi, this is Brian Warmers recording a lecture for Pediatric Nursing, and this topic is neuromuscular dysfunction. So the objectives for this lesson will be talking about CP, meningeal seal, myelomeningeal seal, SMA, Duchenne's muscular dystrophy, tetanus, and botulism. So CP is a group of permanent disorders of the development of movement and postures that cause some inactivity limitations. This usually occurs within the developing fetal or infant brain and is characterized by some abnormal muscle tone and coordination. Incidence is 2.4 to 3.6 per 1,000 live births and is most common permanent physical disability in childhood. This can arise from prenatal, perinatal, or postnatal problems, and there's a strong correlation with this to epilepsy, wherein 15 to 60% of those that have CP also will have epilepsy. Within this slide, there's a link to talk about a little girl who was doing physical therapy and learning to walk with CP. When our patients are hitting these milestones and achieving, we need to celebrate their successes. And this is a great story. I know she can be a little hard to hear sometimes and understand, but nonetheless, it's a wonderful story about her success in overcoming some obstacles. Next topic will be neurotube defects, and this is going to cover a few different things, but realize that all in all, neurotube defects are congenital anomalies, and they've got multifactorial inheritance. One of the biggest complications of this is that this usually occurs prenatally in about 3 to 5 weeks of gestation. So oftentimes the pregnant mother doesn't honestly even know that they're pregnant yet at this point in time. And so taking prenatal vitamins and other prophylaxis is difficult at this time. Incidence of neurotube defects is it's more common in girls than in boys. It occurs more commonly in Caucasians than African Americans. And it's linked to folate, B12, maternal hyperthermia, maternal obesity, and maternal diabetes mellitus. We can detect this prenatally using alpha-fetoprotein, uterine ultrasounds, chorionic villus sampling, and just know that elective pre-labor cesarean birth may lead to a decreased motor dysfunction later on in life as well. So we do have different types of neurotube defects. So this would be a normal. This would be a spinal bifida occulta. Occulta means hidden. So if you're talking about the occult or something along those lines, it means hidden and out of sight. And so that's why this is spinal bifida occulta. You got meningeal seals and then myelomeningeal seals. If the brain is totally exposed, then that would be exencephaly. If there is no brain development, then that's anencephaly. In these stages, the fetus is usually aborted. However, if the fetus survives, the brain does degenerate, and although there's some brainstem function possible, the outcome for this is not compatible with life. With spinal bifida occulta, that's usually on a lower type of situation, so this is lumbrosacral between L5 and S1 on your vertebral bodies. Skin indicators for this include skin depression or a dimple, very common, sacral angioma or a port wine nevus, sacral tufts or dark hair, which is very common, and then soft subcutaneous lipomas, which is like a round little grouping of fat. So what I've most commonly seen is this little skin depression, dimple, kind of right between the gluteal folds at the bottom of their coccyx and sacral area. Spinal bifida cystica, so that's outward, so it's not occulta, but it's cystica, so it's visible. And what you're seeing with this is that you've got the sac out here. This one is intact, this one is ruptured. Both of these become surgical problems and need to be corrected as soon as possible. So our treatment, of course, is prevention. That's always our best medication. So what we do to prevent it would be folic acid supplementation at this rate. If there's a family history of neurotube defects, then we increase it. tenfold. We did start fortifying grains and cereals with folic acid in 1998, and the reason is that, like I said before, by the time the mother realizes that she's pregnant, that neurotube defect might have already developed. Postnatal management, so of course this is supportive care. We're trying to prevent infection, especially if there's a risk for infection due to an opening or an external sac. This would be strongly neurological assessments are going to correlate with this, as well as surgical repair. And then if we can, we like I said, we repair this as soon as possible. Some of these patients will have hydrocephalus, and that will require VP shunts. There is definitely orthopedic management with this related to braces and assistive devices. They might have some genitourinary dysfunction because if it happens that low on the nerves and you get impingement, then you can have problems with voiding and stooling. Prognosis is fairly good for life, but they might have some long-term complications, especially when it's talking about mobility issues and then the genitourinary and bowel control issues. Latex allergies, we cover this in this chapter or in this section because this was commonly associated with those patients that needed to frequently self-cath, because with latex, the more you're around latex and the more you use latex, the higher risk you get. And back in the day, it used to be that the catheters were latex. Now we've gone to non-latex products throughout the hospital pretty much, and the self-catheterization uses non-latex catheters as well. But regardless, for latex allergies, they can have a range of reactions, everything from anaphylaxis to just some itching, wheezing, and a rash. Cross reaction, so it's kind of interesting that patients with latex allergies are at increased risk for banana, avocado, kiwi, and chestnut. High-risk populations include anybody that has to self-cath, like I said, is around a lot of medical procedures or around a lot of latex. The goals, of course, is to reduce exposure to latex and make sure that they don't have a reaction to it, and then create a latex environment, or latex-free environment, I should say. Our next one is SMA, so spinal muscular atrophy. This is a group of disorders characterized by progressive degeneration of the motor neurons. This is where the kids usually start off having some muscle control, but what you see is that they gradually weaken. And then as that progresses, then it can lead to death. And the most common reason for that would be respiratory failure. So you get weakness of your diaphragm, and with that lack of a diaphragm moving good air, that causes respiratory failure. Manifestations of this, so hypotonia. So little infants and little kids are going to be, they might have some tone initially, but then they degress. And the sooner that they degress, then of course the worse the outcomes, generally speaking, are. But you'll notice hypotonia in these patients. You'll also see an infant in frog leg position. And so they won't necessarily move their legs, but what happens is that they kind of bend their knees. They have their heels towards their, like touching their diaper, and then their knees kind of fall open. And that's called the frog leg position. And that's related to the hypotonia. In these patients, you also see an absence of DTRs. They're going to have a weak cry and cough because their diaphragm is weak. And they tire easy during feeding because, once again, related to poor muscle, they have issues with that. Of course, they're not going to meet those developmental milestones, especially when it comes to motor movements. One key aspect of this is that they do have a normal sensation and intellect. In fact, some of these patients are some of the smartest people I know, because they hang out with very intelligent people all day, and they hang out with medical people, unfortunately, for them. Testing includes molecular genetics, looking for the survivor motor neuron. No, it's not the spinal muscular neuron, it's survival motor neuron. And if there's a lack of that, then that's indicative of SMA. Treatment, supportive and systematic cares. Anything from assistive devices into wheelchairs to ventilators to whatever they need. This is a story about Bryce. You can watch it here. Something I want you to think about is reflect on your feelings about, do you think it was all right for mom not to tell Bryce that this is going to have an early mortality with him? And I can go back and forth. I can play devil's advocate on this, but I just want you to reflect on that and what would you do if you were his mom or his dad? So moving on to muscular dystrophy. So this is the largest group of muscular diseases in children. All have genetic origins with gradual degeneration of the muscles. This causes progressive weakness and wasting of skeletal muscles. And with that, it's a loss of strength. So Duchenne's is one of the most most common types. And it's unfortunately one of the more severe types. This is X-linked, which means that this is more prevalent in males. Characteristics of this are an onset between 3 and 5 years of age, which is really tough on parents because they're developing normally and then they start missing their milestones and then actually regressing. You'll also see some calf muscle hypertrophy. You're going to see some generalized weakness. And then ultimately this results in death. And often it's related to either respiratory, where the diaphragm is not working and they get pneumonia or respiratory failure, or cardiac issues, as cardiac is your heart's a muscle. And so if you go into having muscular problems, cardiac failure is a real concern. So manifestations, they're going to walk different. They're going to have a waddling gait. They're going to fall frequently because they lack the musculature to help support and correct and adjust for balance. They might do a Gower sign, and this is where the child needs to walk their hands up. So they maybe start in a plank and they walk their hands towards their feet to try and stand up, and they need assistance with getting up. Lordosis, so this is a curvature of the spine because the musculature can't hold it in place. Enlarged muscles in the calves, especially muscular atrophy later stages, and some of these patients will regress and have some cognitive impairment. Management of this, there's no effective treatment that's been established, but it's all supportive care. You want them to be as independent for as long as possible. So we're talking about assistive devices, adaptive devices, and helping them, not necessarily jumping in, taking over, and saying, "Oh, you poor thing." It's how can we let them live the highest quality of life, and assisting them with that. So tetanus is an acquired thing that we get from vegetative tetanus spores or vegetative spores of Bacillus. And the hard thing about this is this causes a lot of rigidity of muscles. So the exotoxins of this spread throughout the nervous system, and then that fixes on the nerve cells and then produces muscle stiffness and rigidness. So manifestations are going to include tight muscles and stiffness, like in this image, and especially of the jaw and neck. And so that's where the term lockjaw comes into play. So with that, they're going to get difficulty in opening their mouth, facial spasms, breathing issues, and they can get this progressive ophthalmosinosis. With this, they can have tetany of rigid respiratory muscles like I talked about, and that leads into respiratory failure. And so that's definitely a concern if your patient's not breathing. So what we do in those situations is we'll paralyze the patient, relax all those muscles that way, ventilate them, take over, and kind of wash them. So usually if we get them successfully cared for after 4 days, they usually recover well. But it's just seeing this and being able to identify it and treat it appropriately. I will say I've never seen this in my practice. I've only heard of one person in this local region having it, but this is still something that's a significant thing for you to watch out for. Management of this is going to include, prevention, of course, with, the shots or tetanus antitoxin after exposure, treatment of those wounds, and then, of course, high-level nursing care if the person becomes afflicted with this. Last chapter here is botulism. This is food poisoning related to Clostridium botulism. Often the sources are sterilized home canning foods, improper water, honey, and then light or dark corn syrup. Treatment of this is going to include IVIG and supportive care. This becomes a big issue because we're worried about contaminated food supplies, and so the health departments will usually come in on this one and try and figure out where the person got this from and then who else might be impacted by this. All right, this concludes this lecture on neuromuscular dysfunction. If you have questions on this, please contact me.